Hello. Today, I would like to talk about cervical lesions that require differentiation from lymph node metastasis. An elderly male patient presented with a palpable mass in the right lateral neck. On ultrasound, there was a category 4 lesion in the right thyroid, and a relatively large mass in the right lateral neck. The lateral neck lesion showed internal cystic changes. When performing thyroid ultrasound, it is very important to include evaluation of the lateral neck as part of the assessment. Although the right thyroid lesion did not show a typical malignant appearance on ultrasound, the presence of a lateral neck mass with cystic change raised the possibility of lymph node metastasis, and the initial impression was thyroid cancer with lateral neck lymph node metastasis. Fine needle aspiration was performed for both the thyroid lesion and the lateral neck mass. The thyroid lesion was diagnosed as Bethesda Category 3. While adequate cellular material could not be obtained from the lateral neck mass because the patient coughed whenever the needle was inserted. There was no elevation in thyroglobulin on washout. On neck CT, a hypodense mass located between the common carotid artery and the internal jugular vein was identified, showing a characteristic appearance of a neurogenic tumor. Surgical pathology revealed the thyroid lesion to be follicular variant papillary thyroid carcinoma, and the lateral neck mass was diagnosed as a schwannoma. Based on its location, the tumor was thought to originate from the vagus nerve, which explains why the patient coughed during the fine needle aspiration. A young female patient was referred from another hospital due to multiple thyroid nodules. As you can see, there are several bilateral Category 3 thyroid nodules. As mentioned earlier, it is essential to carefully examine both lateral neck regions during thyroid ultrasound. On the medial side of the left carotid artery, a lesion with relatively increased echogenicity was observed. When the probe was rotated to obtain a longitudinal view, the lesion appeared to be fusiform and connected superiorly and inferiorly. On the transverse image, one might briefly consider the possibility of lymph node metastasis from thyroid cancer. But this became less likely on the longitudinal view. I will now show you the transverse ultrasound video. It is helpful to trace the vagus nerve, which runs between the carotid artery and the internal jugular vein. As demonstrated, even if a lesion initially appears suspicious for a pathologic lymph node on transverse imaging, real-time ultrasound tracing can suggest a neurogenic tumor originating from the vagus nerve. This patient had been diagnosed with neurofibromas in the thigh and lumbar spine. Multiple dermal and subcutaneous lesions were also observed in the posterior neck. The patient was diagnosed with neurofibromatosis. Finally, a middle-aged woman who had previously undergone surgery for thyroid cancer presented with a large mass in the posterior neck. Let's review the video. As you can see, this is a neurogenic tumor connected to the brachial plexus. Thank you.